Here in Brazil, we have two different health systems. So we have the private health system, and the public setting. And about 30% of the population is having insurance, but the majority of them don't have, like about 70%. And you have a very distant gap, a huge gap between the options of treatment for patients with multiple myeloma between these two healthcare systems. In the private system, we don't have access to new therapeutic agents, so we have bispecifics approved, so teclistamab, elranatamab, talquetamab. We have cilta-cel approved here, and so we have a lot of different drugs approved. And so in my practice, if I have a patient in a first relapse, usually I do treatment with like Candor or Ikema, but when I have a patient with triple class exposed or triple class refractory, usually I tend to treat with bispecific antibody, because we have some limitations. Although you have approval for cilta-cel, it's not easy to get because we have the brain to vein time. So we have about 6 months that we think about CAR T, and in fact the patient receive the product. So we have a big time that we need to talk with the insurance. Sometimes they don't approve the CAR T because of the costs, even if it's approved in our country. And after that, we need to collect the cells and send the cells to manufacturing, and the total time it's about 4 to 6 months. So it's very difficult to us, and sometimes you don't have this time in this type of population with relapsed refractory multiple myeloma. So usually we are using more bispecifics. And if I have a patient that will be eligible to CAR T cell in the future, not now because of the access, I prefer start with talquetamab as a bispecific because of the data that we can do cilta-cel after and have a good result too.